Good morning, ladies and gentlemen. We are going to continue the topic of joints of the upper limb, where we stopped last time. My name is Kachlík, and I will have this lecture. We continue on the topic of synovial bursa of the shoulder joint, which are shown in this figure. Here we can see big one subacromial synovial bursa, which is connected with this, which is big subdeltoid bursa. These are the largest ones. And the other ones are not shown here, like the subcoracoid, which would be here, and then subtendinous bursa of subscapularis muscle, which would be here, and then two which are on the dorsal side, so they are not visible in this figure. Please do not mix the bursa with this, which is a synovial sheath of the tendon of the long head of biceps brachii muscle, protruding from the articular capsule of the shoulder joint. And to conclude the shoulder joint, here are the movements of the shoulder joint shown. So we have a flexion and extension. So flexion is also called ventral flexion, and extension is also called dorsal flexion. These are not real synonyms, as flexion is the movement ventrally, which you can see here. This is a flexion, and the movement back is extension. And then movement here is the dorsal flexion. But this precise terminology is not used practically. So the ventral flexion is used as a synonym for the dorsal flexion is used as a synonym for extension, although extension should be the movement back from ventral flexion. Then we have here the abduction, and on the opposite side, adduction. Then if we move in front of the body, we call it a hyperadduction. That's already a combined movement. And then, of course, we have these kind which are rotations, external and internal. You can see here also the extent. As you can see, the extent of the dorsal flexion is lesser than the extent of the ventral flexion. The abduction is up to the horizontal plane, and what is above is allowed only with external rotation of the shoulder blade of scapula. And as you can see, rotations are also allowed until 90 degrees. Circumduction is the combined movement when we combine ventral flexion, dorsal flexion, abduction, and adduction. And at the end, normal X-ray of the shoulder joint, where you can see glenoid cavity and humeral head, the articular surface of it, and here you can see the cavity of the acromioclavicular joint. A special projection, which is called Y projection of the shoulder joint, to nicely show this. That means acromion here, and spine of scapula is here, and coracoid process then here. That's the coracoid process, and this is the superior border of scapula. And of course, nicely visible glenoid cavity here. And the larger structure is humeral head. The scapula itself then continues here down to the inferior angle. You can see here the distance between scapula and thoracic wall. In between we find muscles, and upper limb or scapula and thorax are joined by scapulothoracic juncture or joint, which is only a functional joint. Yeah? That's neither synovial nor synarthrotic joint. It's just a functional connection via muscles and fascia. And here, if you can see a posterior dislocation of the shoulder joint, which is quite rare, but you can see the difference if I move back. You can see what is the different position between these two structures, between the healthy patient and the ill patient. And that's another X-ray showing luxation ventrally. Yeah. So then the luxation ventrally then closes this area, yeah, and the bone is rotated to the ventral side as well. And MRI showing here the humeral head, which is here. Yeah, this is the articular part, and the greater tubercle then here. And then structures which are close to the joint. That means this is the glenoid cavity. The articular cavity is in between. So we can see even the labrum here and on the other side. And this is the tendon of the long head of biceps brachii muscles. Okay. On this section here again, we can see the head, and the biceps is here. Yeah, that's the tendon of the long head of biceps. The dark structures, these are muscles. Yeah. This is, for example, coracoid process. And here we can see acromion and clavicle. So that's for MRI. And now we can move to the free limb farther to elbow joint. Elbow joint or articulatio cubiti is a joint compound of 3 bones and biaxial, and these bones are, if you look here, humerus proximally, yeah, which we can see here, radius distally with its head, and ulna distally and medially with its olecranon on the dorsal side being the most proximal part of forearm bones. Yeah? So it's a compound joint, compound of 3 joints. As you can see, these joints are each different. Humero-ulnar is trochlear. Why? The head is trochlea, and when it's a trochlea, it has to be a trochlear joint, and for that, the fossa is the trochlear notch of ulna, yeah? Which we can see then. I'll just erase it. Which we can see here. That's the joint here. This is trochlea and the trochlear notch. So this is humero-ulnar joint, and that's monoaxial trochlear joint. The other joint is humeroradial joint. Humeroradial is spheroidal bone, spheroidal joint, yeah, because the head is capitulum, in translation small head, so it means it's a ball, And the fossa is articular fovea on radius. Yeah? When we look at them, how they look like, we can see the head, which is a part of the surface of a ball, and this fovea, which is here on this surface, and it is a real fovea, so it's like that. Yeah. So that's why it's a ball and socket or spheroidal joint. So it's 3-axial joint. And the last one is proximal radioulnar. Yeah, and the proximal radioulnar is a pivot. That means it's also 1-axis joint, so monoaxial joint, but its long axis is, as you can see here, the long axis of this joint is parallel with the axis of the limb. That's why we call it a pivot joint. Yeah? So the head in this joint is circumferentia articularis, articular circumference, and the fossa is a radial notch of ulna. Yeah? So if you look at the figure, you can see the circumference is this one, and it's turning around in this quite shallow notch, radial notch of ulna. Yeah? And this is monoaxial. So we have a monoaxial here, and then 3-axial here. So then the function is, this is a biaxial joint, yeah, which allows us, one movement is this, the axis, that's flexion extension. We are not able to perform abduction and adduction because this is a trochlea, and we have thick collateral ligaments, which you can see here. But we are able then to move these two bones. That means radius then turns across ulna, which we call supination pronation. So functionally, it's a biaxial joint. So as I said, functionally, it's a biaxial joint, flexion extension, and pronation supination. So we have talked about the joint type, head and fossa. Articular capsule leaves outside epicondyli, which serves for muscle origins. Yeah? But then it inserts along the articular surfaces, and it forms small saxiform recess, which I'm going to show you. Yeah, small saxiform recess distally. As for ligaments, I mentioned that 2 collateral ligaments, which are called radial and ulnar, these ligaments limit abduction and adduction. Yeah. And then we have another 2 ligaments, annular ligament of radius and quadrate. Quadrate ligament is just a small thickened part of the articular capsule and forms the distal border, that means the floor of saxiform recess. And the ulnar collateral ligament has got 3 parts. I'm going to show you humerocoronoid, between the humerus and the coronoid process of ulna, olecranohumeral, and an oblique part. So let's go to figures to see all the mentioned structures. This is saxiform recess, yeah, distally. Find it distally, and the floor of the saxiform recess is called quadrate ligament. So quadrate ligament can be well seen from distally, and is the floor of the saxiform recess. So then we see here the collateral ligaments, yeah? Radial and ulnar. And then this ligament is the annular ligament of radius, this or this. This is insertional tendon of biceps brachii. Yeah? It's not part of the joint. Well, when we move here, we can nicely see the ligaments here, yeah, the radial collateral ligament, and the ulnar collateral ligament, and the annular ligament. The quadrate ligament would be somewhere here in the depth. It's just the distal border of the saxiform recess. So these figures are just for you to study at home and to see nicely the shape of the ligaments. This is the radial collateral ligament, which has a shape of like fan-shaped one. And if you look at the ulnar one, we can see the three ligaments, the oblique and the humerocoronoid, as this is the coronoid process, the humerocoronoid, and then the olecranohumeral. So here you have the three parts of the ulnar collateral ligament, which also then finally makes a fan shape, makes a fan shape, but it consists of three independent bands, unlike the radial, which is consistent. So what we can see in this figure is the annular radial ligament, which keeps the head of radius in the radial notch of ulna. So it's around here, and supports radius during pronation and supination. So there are of course some bursae, as you can see here. Two bursae are dorsally. One is called the student bursa. It's the superficial olecranon bursa, and when the students study and they are leaning against their olecranon, then they can have inflammation of the student bursa. Then this deep olecranon bursa is between the tendon and the bone. So this we call subtendinous bursa of triceps brachii muscle. So that's this one, and this one is here. And then we can find some bursae ventrally, like bicipitoradial at musculus bicipitoradial here between the tendon of biceps and the extensors, which are situated on the radial side. So these are the bursae. These two dorsal are the most important. This is again the student bursa or the subcutaneous olecranon bursa. Another structure which can be found here, but is missing in many books, is this one, which is the elbow fat pad. This elbow fat pad, which you can find on dorsal sides here and here. It again helps to fill the incongruity, and we can find it in the fossa, so in the olecranon fossa and in coronoid fossa. Okay. As for the movements of the forearm, of course, flexion, which you can see here, and the flexion comes to 145, 150 degrees. Then the movement back is extension. It goes usually to 0. It can go farther, up to 5%, up to 5 degrees, and it's based on the massiveness of olecranon and on the thickness of the septum between olecranon fossa and coronoid fossa. As here the bone can even be absent, then we have here an opening. If I come back, show you, it is this area. And if we in this area have an opening, then it's easier, and we have smaller olecranon, then it's easier to perform extension here. And the opening is called foramen. supratrochleare. Yeah? Foramen supratrochleare, which is present in less than % of cases, especially in gracile women. So these allow an so-called hyperextension. So that's extension and flexion, and of course movements of the forearm in the sense of pronation, supination, that's 90 degrees to both sides. So that's all for the movements. And now some x-rays. On the x-ray here you can see olecranon here. And here we can see the trochlea. That's the trochlea and coronoid process and the trochlear notch on ulna. And different color will show capitulum and articular fovea of radius and head of radius. Okay. So you can see this is normal position when radius terminates more distally and ulna more proximally. Yeah? And also the corresponding articular surfaces on humerus are not in the same plane, but capitulum is located more distally, trochlea more proximally. We also use antero-posterior projection. Here you can nicely see capitulum and radius. Yeah, the fovea here, and quite proximally locates its olecranon, fossa olecrani here, yeah, and coronoid process of ulna here. And these X-rays show some pathological situation. Here is posterior luxation of the joint. As you can see, the trochlea is out of the notch and the olecranon is located dorsally. Or we can have even in long axis existing luxation, then divergent luxation to the side, as you can see here. Yeah. And again, there's a luxation of the elbow joint shown more in detail. And especially in kids, if you pull them too much, maybe during walking, you can cause a subluxation of the joint. Yeah, you can see the normal position here. And then this shift proximally in this direction, yeah, which is called a subluxation. It may not be visible, but it's very painful, and the hand is in pronation, so it's called pronatio dolorosa, painful pronation. And of course, here on this X-ray, you can see that there are still growth plates, so it's not a fully ossified, fully matured patient. Yeah, still you can see the growth plates on both sides. In this case, even there is not an epiphyseal core, no ossification has begun in the proximal end of radius in the head. So, and then we continue from the elbow joint more distally, and between two forearm bones we find a big syndesmosis. Yeah? This syndesmosis is composed of different fibers, thinner and thicker. The basic division is into this, which we call corda obliqua, oblique cord. Yeah? As you can see, the direction of the fibers is from ulna to radius, distally. Opposite direction from radius to ulna distally is here in this larger area, which also consists of smaller other bands, but we can skip all the names of these. We just call it interosseous membrane of forearm or antebrachial interosseous membrane. We have here two openings, in here and in here, which we call a hiatus, proximal and distal hiatus. And what is the content of these proximal and distal hiatus? The content is, of course, interosseous vessels. This interosseous vessels, they pierce through and descend on the anterior and posterior aspect. So these openings serve for interosseous vessels. Very rare case can happen when this membrane or the whole syndesmosis is ossified. Then what happens is that pronation and supination is not allowed, and the people are not able to perform this, and so it limits their movements and their everyday life. Well, another joint is the distal radioulnar joint. When I'll come back here to show, we have the proximal radioulnar joint, which is an integral part of the elbow joint. And we have the distal one, which is a separate joint. Both these joints have to work together. They have to function together, otherwise pronation and supination is not allowed. So it's a functional complex. And as for the distal joint, it's very easy. It's a simple mobile pivot joint, the same as the proximal one. The head is again a circumference, but this time circumference of ulna. The fossa is, as for the proximal, a notch, but this time ulnar notch of radius. We have a saxiform recess, as in the proximal joint. This time the saxiform recess directs proximally, not distally, but proximally. Movements are the same for both joints, that means pronation, supination, and neutral position is a mild pronation. So this is a very, very easy joint with no problem. And on this X-ray you can nicely see the joint shown here. Of course, this joint can be harmed, and you can see that the position of the bones is not correct. So here's the luxation in the distal radioulnar joint present. And we have quickly moved to the wrist itself. The wrist is complicated, as is composed of 8 carpal bones, 5 metacarpal bones, 14 phalanges, and some sesamoid bones. So the hand works as a functional unit, and there are special wards in hospitals called the surgery of the hand, as it is very important for us and of course unique for humans. So it is composed of the wrist or radiocarpal joint, which we find here. Then it's composed of intercarpal joints, and we have a line between the proximal and distal row, which we call medial carpal. And then of course we have the continuation here, which is carpo-metacarpal joints. And these carpo-metacarpal joints are here like arthrosis. They move only slightly, like this, which is carpo-metacarpal joint of the thumb. There's the saddle joint, that's a very specific joint. Of course, there are ligaments, and there's one disc. The disc is located in this free space. And the hand as a whole, and we will talk about it then at the end, performs flexions and ductions. Yeah, no rotation is allowed based on the wrist joint, as I will show you. So this is just an introduction. Now let's look closer here. Yeah, this is the area of the disc, which is shown here. So the disc then separates ulna and the carpal bones. So then that's why the joint will be called radial carpal. Yeah, and the wrist joint is called radial carpal as ulna is not in contact with carpal bones. So the wrist joint, as we have seen, is more bone, so it's compound. It contains discus, so it's a complex joint. Yeah? And as for the movements, it's ellipsoid. Yeah? It allows only palmar flexion and extension. Yeah? So palmar flexion, dorsal flexion, and ductions, yeah? Radial and ulnar. Okay, what is the head? The head are carpal bones. Proximal line from lateral to medial, scaphoid, lunate, and triquetrum. Fossa is radius and the carpal articular surface plus the disc. Are there some ligaments? Yes, there are, and you can see which. They are very weak and negligible collateral ligaments. Yeah, so these really we can skip as they exist there just as a thin remnants. But then we have thick ulnocarpal and radiocarpal on both sides. So palmar dorsal and palmar dorsal, radiocarpal and ulnocarpal. Yes. So now we can look again here and repeat that the head is formed by scaphoid, lunate, and triquetrum. Yes, that's the head. The fossa is carpal articular surface of radius and the articular disc. So ulna is not there. And the collateral ligaments are very thin, and thicker are ligaments which are called radiocarpal and ulnocarpal, dorsal, and palmar. So again, figures showing the same, just beware of the sides. Here radius is on the other side, that ulna, then here. Yeah. So first look at the figures and realize which side is where. What we can nicely see here is a cavity of distal radioulnar joint, and this is the succiform recess. Yeah. Then this is the disc. And here we have radiocarpal joint. And then we will have a medial carpal joint in here. So that's the sequence of these joints. And clinically, the structures which are located here are called triangular because the articular disc has got a triangular shape. Fibrocartilaginous complex, as the disc is cartilage. And the fibrous part are these ligaments. So the cartilage is visible, and these ligaments which are here is the ulnar radiopalmar ligament and dorsal radioulnar ligament. That means the ligaments which are located here. Collateral ulnar carpal ligament, thin one, but located still here. And what is called ulnocarpal meniscus, that's a small fibrous structure which is located here. Definitely the disc and the ligaments which are around forms triangular fibrocartilaginous complex, or TFCC, which is very important in clinics and in operations here. Yeah. So please remember this clinical term, TFCC, triangular fibrocartilaginous complex, and you have to know that it is composed of the disc and ligaments. Yeah. That's the most important information. You can see it nicely here in the opened joint, where you can see the scaphoid, lunate, and triquetrum. You can see the radius, the carpal articular surface, and the disc. And what is here around these structures are the ligaments of TFCC. So that's a clinical term I used. The TFCC would be located here. Yeah. And you can see the scaphoid, lunate, and triquetrum. Pisiform bone is, of course, ventrally or palmary from this area, so it could not be part of the joint. And here you can see nicely luxation as the bones overlap here. Yeah, and the overlap should not be here, so this is radiocarpal luxation. Another joint which is in close vicinity is the medial carpal. The medial carpal joint is a long curved cleft. It's a compound joint and it has got two heads and two fossae. One head is hamate and capitate. The other head is scaphoid. And hamate and capitate articulates with scaphoid, lunate, and triquetrum with their concave parts, and the convex part of scaphoid articulates with trapezium and trapezoidum. So it may sound complicated here, but if we look at some figure, for example here, so you can see this is the first part. The hamate and capitate form one head, and their fossa is here. So triquetrum, lunate, and scaphoid. Yeah. And then the other fossa is here. Trapezium and trapezoidum. And the head is this part of the scaphoid. So you can see it is a S-shaped joint, which is formed by intercarpal joints altogether. Yeah? And it's in the center of the wrist, that's why it's called medial carpal joint. What about the ligaments? Of course, we have ligaments from dorsal side, from palmar side, and even between bones, interosseous, and we call them intercarpal as they interconnect carpal bones. And on the ventral surface, from the capitate, from the head of the capitate, which is the functional center of the joint, runs the radiate carpal ligament, which is composed of small ligaments. They all have names, but their knowledge is not necessary for the students of medicine. It is just for specialized surgeons of the hand. Yeah? Okay. So we can see the ligament here, nicely shown the S-shaped articular cleft, or the articular cavity. And here is a drawing of the radiate carpal ligament. And the very center of it is the head of capitate. So that's the radiate carpal ligament. And then some thicker parts are in between the head of capitate and ulna and radius, and we call them radiocarpal and ulnocarpal palmar. And of course, we have dorsal as well. And these are the thickest and the most important. And of course, we have intercarpal, palmar, interosseous, and dorsal. Yeah, but we are looking for the ventral side, so we do not see them. So that's for the ligaments. Of course, if we come closer to that, and this is the information more for surgeons of the hand, you can come and see a special term. Some of the ligaments, the intercarpal ligaments, are thicker, some are thinner. So nicely we can see here radiocapitate, which is this one. You can see radiotriquetrum, which is this one. Yeah. And we can see radioscapulatum, which is a bit hidden below. Yeah. That's the ligament, and you can see part of it. That's this, yeah, and it's hidden below, like in this extent. So these are 3 ligaments from clinical point of view which are important. On the ulnar side, we have ulnolunate and ulnotriquetrum, which are here. And they form the palmar ulnocarpal ligament. So you can see that the radiocarpal and ulnocarpal palmar ligament consist of smaller strips, and the name of them are important for the surgeons of the hand, not for you. Yeah, not for you like students, it is not necessary. And the last ligament shown here and clinically interesting is the capitato-triquetrum ligament, which is this one. Yeah, so that's the clinical point of view, but I said it is not necessary for you to know all these ligaments on this slide by heart. Okay, what is clinically very interesting is this one, that when you perform a radial or ulnar adduction, then the ligaments can form such openings. As you can see, they form a V shape, and these V shape they can open or close such a shackle. Yeah, and this space which is then left here is called a space of Poirier, and in the space of Poirier is a thinned wall. Yeah, the connective tissue, the ligaments here are thinned, and it allows a luxation of lunate. And the most common injury of the wrist is fracture of scaphoid bone. Yeah? We have talked about that in bones, that it does not heal very well due to its poor blood supply. But the second most common injury of the wrist is luxation of lunate. And the luxation of lunate, why just lunate, or why specifically lunate? It's because of this space, which you can see here, and the lunate bone is underlying this space of Poirier. So these, the ligaments, the smaller ligaments, which names are listed here, radiotriquetrum, ulnotriquetrum, radiocapitatum, and capitatotriquetrum. In between these, we find a space of Poirier, which has a weakened wall, and the lunate can luxate in this direction. So this is a ventral luxation. Yeah. Okay. And the luxation then looks here. You can see how the lunate, and you can see the lunate shape here moved ventrally. And of course here, the position of lunate is not nice. You can see here the overlapping of the other bones. So you can see that the bone is luxated. Yeah. Okay. That's luxation of lunate. If you look dorsally, we have also here some ligaments. Again, Radial Carpal and Ulnar Carpal. Ulnar Carpal dorsal and Radial Carpal dorsal, consisting of other smaller ligaments, which names are not so important. And then this is an area of dorsal intercarpal ligaments. As I said, the collateral ligaments are very weak. Okay, movements of the hand as a whole. Okay, flexion and extension. But as we could not say what is flexion and extension, again we call it palmar flexion. Yeah. The movement back should be extension, and the movement farther should be dorsal flexion. But that's again a very precise nomenclature. Usually we call it plantar flexion and dorsal flexion, and dorsal flexion is a synonym for extension. Yeah? So it depends. If you are a specialist in movements, then you really distinguish between extension and dorsal flexion. But in general language, we just dorsal flexion and extension is for us the same. The same palmar flexion and ventral flexion and volar flexion. You can meet this. So palmar flexion is the same as ventral flexion is the same as volar flexion. As the word vola is the same as palma, is the same as palm, yeah, part of the hand. As for ductions, you can see altogether it's some 60 degrees, and of course ulnar duction is it's larger than radial duction. Yeah, you can try it yourself just now. As to proceed from the hand, we come to carpometacarpal joints. All the carpometacarpal joints, except the first one, are plain, simple joints. They are amphiarthrosis, no special movements. But the first carpometacarpal joint, or the carpometacarpal joint of the thumb or of pollex, is special. It is simple mobile one, but it's a saddle shape. We have already talked about that during the general arthrology. The head is the base of first metacarpal. The fossa is trapezoid bone. Yeah? And in between we find the saddle-shaped surface. It is strengthened with ligaments. The names are very easy. Carpometacarpal, again from 3 sides, dorsal, palmar, interosseous. Yeah? And then the functions we will show. So you can see the basic function, which is flexion extension. Yeah? Flexion and extension allows us quite large movements, altogether again 60 degrees. Then abduction, as you can see here, abduction allows even 70 degrees. And then movement, which is combined, movement of the carpometacarpal joint and of course the Metacarpophalangeal joint is the opposition and reposition of the thumb. Yeah? So this saddle joint allows us to perform these complicated movements in all 3 axes. As this joint is very overloaded, yeah, mainly in physiotherapists, chiropractists, it suffers from arthrosis, and we call it wrist arthrosis. Yeah, when we have problems in this joint, And we can even perform a total replacement of this joint, yeah, of the carpal metacarpal joint. So it's possible. So how the whole hand then works, you can see it here. Of course, we have talked about the thumb itself, yeah, and the carpal metacarpal joint, but altogether, all 5 fingers can perform plantar and dorsal flexion. Yeah, you can try that, the dorsal flexion. I just moved here the video, so maybe you can see it. So we perform palmar and dorsal flexion. Again, palmar flexion and extension, which is the same as the dorsal flexion. Yeah. So what then we can perform again is radial and ulnar adduction, which is this one. Yeah. And the axis is the 3rd finger. So we have adduction, abduction. Yeah. Of course, we can perform circumduction, a combined movement, but you can try a passive rotation. The passive rotation is possible related to the shape of the head, as you can see it here, the shape of the head, which is like a ball and socket, but we have no muscles to perform that. Yeah, that's why you are not able to perform rotation, but you can rotate passively. Okay, there are some important topographical structures here. We have learned that there are 2 bony eminences. We call them radial and ulnar carpal eminence. The ulnar one is produced by pisiform bone proximally and hook of hamate distally. The radial carpal eminence is produced by tubercle of scaphoid here proximally and distally by tubercle of trapezoid. And in between is stretched very thick ligament. And this ligament serves to keep here tendons. That's why we do not call it ligament, we call it retinaculum. Retinaculum of flexors. So flexor retinaculum, and in Latin retinaculum musculorum flexorum. Retinaculum of flexor muscles. Yeah? And in between these, that means ventrally the retinaculum, laterally and medially eminentia, and dorsally the ligaments, the palmar ligaments of the carpal bones. It forms a carpal tunnel. In Latin, canalis carpi. In English, usually carpal tunnel, sometimes carpal canal. And you can see the eminences here. The retinaculum, which also used to be called a transverse carpal ligament. Again, when we come to specific anatomy, it is not really the same, but for practical purposes, you can consider it the same, but please prefer the term retinaculum. Yeah. Retinaculum, flexor retinaculum, or in Latin, retinaculum musculorum flexorum. And what is the content? You can see here tendons of flexors. Yeah. There are 4 muscles, 2 flexors of fingers, that means flexor digitorum superficialis and profundus, 1 long flexor of thumb, which is this one, flexor pollicis longus, and this one, flexor carpi radialis. Yeah, the content now is not so important. The important are the borders, and there are tendons. Yeah, you can count the tendons. There are 10 tendons, and 1 nerve, median nerve. And this is what you have to learn, the median nerve and tendon of flexors. If you work too much with your fingers, and nowadays it is mainly using the computer mouse, then the muscles get irritated, swollen, they compress the nerve. And the first symptoms of compression of the nerve, that means the first symptom of carpal tunnel, are usually night paresthesia. So you feel ants, like ants walking on your fingers. And then later you start to lose also the motor functions, mainly the functions of the thumb. And it's tested by this. You ask to pitch something to take it into these 3 first fingers, yeah. And if you are not able to do it, you have tested paralysis of the median nerve. So remember, carpal tunnel is bordered by bony eminences, dorsally by palmar ligaments of the carpal bones, and ventrally by retinaculum. It contains 10 tendons of 4 flexors. So you can remember 10 tendons of 4 flexors. Of course, they are in their synovial sheaths, and 1 nerve, median nerve. Yes? So that's carpal tunnel. We will come to that again in muscles and in topography. Another canal is ulnar canal. Yeah? We can see that the ulnar canal is located here. And maybe we can see it also here. So it's located superficially, ventrally from the retinaculum. The content is again a nerve, ulnar nerve, and ulnar artery. So unlike the carpal tunnel, where we find only median nerve, in ulnar canal we have ulnar artery and vein and nerve. So you can see it here. It's called also a Guion, canal of Guion. Yeah. And you can see here how especially the deep branch of the ulnar nerve there is passing here deep below the ligaments. So please, in the wrist we have 2 canals. Larger carpal tunnel with median nerve and 10 tendons of 4 muscles, and smaller, superficially located ulnar canal of Guion for ulnar nerve and ulnar vessels. Okay, we have to continue with the joints further. Now we are reaching digits. Yeah? And between the digits, we have Metacarpophalangeal joints. So now we are here, and you can see the Metacarpophalangeal joint, and then 2 interphalangeal joints which are identical, yeah, proximal and distal. So now let's talk about the Metacarpophalangeal first, which is again a simple mobile, but quite specific as for the shape. You may remember what is the shape. I'll skip it, I'm sorry. I skip it too much, but we can see it here in this figure. Here, this shape is quite specific. Dorsally, it is ball, but ventrally, from here, it's a trochlea. Yeah, you can look at the bones then, but the shape changes from ball to trochlea. So it allows 3 axes dorsally, but only 1 axis. As you can see, this is also trochlear. Only 1 axis ventrally. What does it mean? Functionally, this joint is ellipsoid. When we come back here, this joint is functionally ellipsoid. Yeah? And again, on video, we can see. So what you are able to perform with this joint: flexion, extension, and what about the other axis? You are able to perform the passive rotation. That's why it's a dorsally 3-axial joint. And you are able to perform abduction and adduction. But this is possible only in extension, when the joint is at the dorsal surfaces. If you perform flexion, try to abduct and adduct. It's not possible. If you do it, then the fingers go dorsally. Yeah. So in extension, when the dorsal surfaces are in contact, you are able to perform abduction, adduction. In flexion, when the surfaces are at the ventral trochlear monoaxial part, you are not able to perform abduction and adduction. Yeah? That's why this joint is functionally ellipsoid and anatomically combination of spheroid and trochlear or cylindrical. The head is a head of metacarpal bone. The base is, the fossa is the base of phalanx. Not only that, also there's a special structure which is called palmar fibrocartilage. So this fibrocartilage enlarges the fossa, which we can see here. Yeah, this is the head. This is the fossa, and the fossa is enlarged with this fibrocartilage. And it's also valid for the interphalangeal joints. They also feature such a palmar fibrocartilage. Okay, as for the ligaments, they have collateral ligaments. Yeah? That means on the side, and these ligaments also do not allow to perform abduction and adduction. And we have one palmar ligament which covers totally the fibrocartilage. Yeah? It encompasses the fibrocartilage. And then between all the heads, we find a transverse deep metacarpal joint. Yeah? So it is somewhere here between the heads of the cartilages, you find a deep transverse metacarpal ligament, yeah, which fix the heads together. So as for the functions, flexion, extension, abduction and adduction, or ulnar and radial adduction only in extension, yeah, not in flexion, and of course circumduction is possible. So this for Metacarpophalangeal joint. Yeah? Here you can see the collateral ligaments and the palmar ligament, which encompasses the palmar cartilage. Yeah, you can see the term volar plate is a clinical term for the palmar cartilage, fibrocartilage, palmar fibrocartilage. And the last joints are interphalangeal. Yeah, they are really identical, so they are simple mobile trochlear, monoaxial, because the head is trochlear of a phalanx and the fossa is the base of phalanx. So it's a groove for a crest, so it's an easy monoaxial flexion extension joint with collateral ligaments and ventrally palmar ligament comprising fibrocartilage. Yeah. So nothing complicated about that. Here you can see again collateral ligament and palmar cartilage within palmar ligament. If you play basketball, for example, or volleyball, and the ball comes against the finger can be diverted to the side, and you then harm the collateral ligaments here. Okay, so to proceed, here you can see where we can find fibrocartilages. Yeah? So we have fibrocartilages here in the Metacarpophalangeal area and then in here in the interphalangeal area. So how many of them we have? We have 4, 8, 12, 13, 14 palmar fibrocartilages. Yeah. Okay. And we are approaching the end. What are vincula? One vinculum is this. In English, it's called pulley. Yeah. So in English, it's pulley. And these pulleys keep the synovial and fibrous sheaths, as here we do not have only synovial, but also it is covered with the fibrous layer. So we have this sheaths for a flexor. You can see here two muscles, superficial and deep flexor, the tendons. Yeah, we have talked about these tendons in the carpal tunnel. As I said, there are 10 tendons, and 8 of them are these 4 superficial and 4 deep for 4 fingers. Yeah, the thumb is specific. And these two flexors, then they insert on different sides. Superficial inserts here, and deep inserts here. But still, for them, we need outside one sheaths, and the sheath is supported or kept in the position by the pulleys. So you can see that some of the pulleys are just a strap, and the strap is like that. So it is an annular one, and the other one is going like a cross. So we call them cruciform. Oh, I miss here. Cruciform and annular. And you can see that we switch them. So we have annular cruciform, annular cruciform, annular cruciform, annular cruciform, and annular. And to know which of which is where, we just mark them A1, C1, and then we continue as far as A5. There is no C5. Yeah? And some of these pulleys can be harmed during some injuries, and then they are repaired by plastic surgeons. So please remember that synovial sheaths and fibrous sheaths, better together, tendinous sheaths on fingers are fixed by vincula, by pulleys, featuring annular and cruciform part, altogether 9 parts, which can be ruptured and can be then repaired surgically. Okay, just to conclude about the joints, we have for the movements of the whole hand, we have the ellipsoid joint at the wrist, so the wrist joint, the saddle joint here, which is the first carpal metacarpal, or the carpal metacarpal joint of the thumb. Then we have these trochlear joints or hinge joints, which are proximal and distal interphalangeal joints. And then we have this specific joint, which is dorsally spheroid, ventrally trochlear, so hinge joint, and functionally it is again ellipsoid, yeah? Not anatomically, but functionally. And then we have these, which are planed amphiarthroses, so we just need to have slight movements in all directions here, and of course in medial carpal joint as well. Okay, so that's all. That's all for today and for the joints of the upper limb. Thank you very much for the attention, and I can answer your questions by email or at the practicals. Thank you very much for attention, and goodbye, ladies and gentlemen.